For this lecture, we are going to discuss brain damage and recovery. So some of the causes of brain damage that we're going to focus on in this lecture are brain tumors, cerebrovascular disorders, closed head injuries, infections of the brain, neurotoxins, and then genetic factors. Okay? All 6 of these brain damages or types of brain damage are characterized by necrosis, which is passive cell death, or apoptosis, which is programmed cell death. And we'll talk more about apoptosis as we go through here. But let's go ahead and start with brain tumors. Okay. A tumor is a mass of cells that grows independently of the rest of the body. Okay, so a cancer. Cancer is an abnormal growth of cells. Okay. In the brain, we're specifically looking at encapsulated tumors, okay, so it says 20% of brain tumors are meningiomas, okay, which means that they're encased in meninges. Okay. They are encapsulated, which means they grow within their own membrane, and they're usually benign, which means they're non-cancerous, okay. Unfortunately, though, most brain tumors are infiltrating, which means that they grow diffusely throughout surrounding tissue. Some examples of infiltrating tumors could be gliomas, okay, developed from the glial cells. Unfortunately, these are pretty common. The infiltrating are usually malignant, which means they're cancerous. They're difficult to remove and to destroy completely. Oftentimes, surgeries will be done where they'll remove as much of the malignant tumor as they can, but it could grow back. Okay. Many brain tumors originate in the lungs, and these are called metastatic tumors. Okay. So if it begins in the lungs and then it moves to the brain, it is considered a metastatic tumor. So in the picture on the right there, you can see a meningioma growing within the meninges, an encapsulated brain tumor, usually benign and fairly easy actually to remove. Okay. On the left-hand side, you see a neuroma. Okay. What about cerebrovascular disorders? So stroke, which is a sudden onset cerebrovascular event, can cause brain damage. For instance, cerebral hemorrhage, which is a bleeding in the brain, can occur. Okay. A type of cerebral hemorrhage could be an aneurysm, a weakened point, any blood vessel that makes a stroke more likely. Now, aneurysms can be congenital, present at birth, or due to a poison or infection. Oftentimes, the congenital type, right, these are present at birth, and then while the person ages throughout life, especially accompanied with high blood pressure, then that's what can cause the aneurysm to eventually occur. Also, not only cerebral hemorrhaging do we have here for stroke, but also cerebral ischemia. Okay, that is the disruption of blood supply. That can happen through a thrombosis, a plug that forms in the brain. It can happen through an embolism, which is a plug that forms somewhere else in the body and moves to the brain, or by arterial sclerosis, which is a thickening of the wall of the blood vessels, primarily due to fat deposits. Okay. On the right-hand side here, you see an angiogram. We talked about cerebral angiograms a while back that illustrates narrowing of the carotid artery, the main pathway of blood to the brain. So this is not ruptured yet, but it could definitely become an aneurysm. Okay, a little bit more on the focus here of cerebrovascular disorders. Again, ischemia, right? Lack of blood supply to the brain. Does not develop immediately. It does not occur equally in all parts of the brain. And the mechanisms of damage vary with the brain structure affected. So that makes sense. Blood-deprived neurons become overactive and release glutamate, which causes damage. And then the glutamate overactivates its receptors, causing influx of sodium and calcium, thereby triggering the release of more glutamate. And this excessiveness of glutamate will actually ultimately kill the neuron. So in the figure on the left-hand side, you see number 1, blood vessel becomes blocked. Number 2, neurons that are affected by the ischemia release excessive glutamate. Number 3, excessive glutamate binds to NMDA receptors, thus triggering an excessive influx of sodium and calcium into the postsynaptic neurons. And then finally, number 4, the excessive influx of the sodium and calcium eventually kills postsynaptic neurons, but first it triggers the excessive release of glutamate from them. And so therefore it's spreading the toxic cascade. Okay? So this is why stroke, it's very, very important that the blockage is dealt with as soon as possible, or else there will be extensive neuron death. Okay? And this would be the necrosis. Okay, what about closed head injuries? So brain injuries due to blows that do not penetrate the skull, but the brain collides with the skull itself. You may have heard of the term contre-coup also. That is a contusion, okay, that occurs on the side of the brain opposite to the blow. On the right-hand side, the figure there, you see that subdural hematoma. It's basically a bruise, okay, on the left side, the left hemisphere there, and it's pushing in on the ventricle, so you can see that the left ventricle is much smaller than the right ventricle. Okay. So it's displacing the brain because of that pool of blood that's there. So contusions or closed head injuries that involve damage to the cerebral circulatory system, in the case of the figure that you're looking at right there, hematoma. But there's also concussions, right? A disturbance of consciousness following a blow to the head and no evidence of structural damage. While there is no apparent brain damage with a single concussion, multiple concussions may result in chronic traumatic encephalopathy. And we're hearing more and more about CTE as it's studied in athletes. Okay. Okay, now we move on to infections of the brain. So you may have heard the term encephalitis, okay? Inflammation of the brain, the resulting inflammation of the brain by an invasion of microorganisms. I gave you some examples here. Bacterial infections often lead to abscesses. They may inflame the meninges, okay? So an inflammation of meninges is going to be meningitis. That's what that term means. Treated with penicillin or other antibiotics. And an example here would be syphilis. Okay. You can also have viral infections. Some of these preferentially attack neural tissues, okay, like rabies. Some can lie dormant for years. And examples that I give you here were rabies, mumps, and herpes. Okay, neurotoxins. So neurotoxins may enter general circulation from the GI tract or the lungs or through the skin, and may cause toxic psychosis, which is the chronic insanity produced by a neurotoxin. A good example here, you've probably heard of the Mad Hatter. And why in the world does he have the name of the Mad Hatter, right? Well, hat makers in the 18th and 19th century in England often had toxic psychosis due to mercury exposure. Okay. So what they would do is that they would dip the hat in mercury and then they would put it on their own head to stretch the leather out, okay, so that they could size and fit the hat, right? But through repeated exposure, this mercury seeped in through the skin, okay, and then would cause the toxic psychosis. Also, some antipsychotic drugs produce a motor disorder called tardive dyskinesia. Okay. So this is what we see when we have very strong antipsychotics that knock out dopamine in the system, and dopamine is therefore very much needed in motor movement. And so since the drugs are not selective, or not as selective as one would wish, then it knocks out dopamine all over the place. And so because of these low levels of dopamine, we see motor disorders such as tardive dyskinesia. Okay, and then genetic factors. So most neuropsychological diseases of genetic origin are associated with recessive genes. And I gave you one example here with Down syndrome, occurs in 0.15% of births. Okay? An extra chromosome 21 is created during ovulation. And there's the characteristic disfigurement, mental retardation, and other health problems associated with this syndrome. Okay, now we switch gears a little bit and we look at some neuropsychological diseases. So we're going to focus on epilepsy, Parkinson's disease, Huntington's disease, multiple sclerosis, and also Alzheimer's disease. Okay, so let's begin with epilepsy. The primary symptom is seizures. Okay, but remember, not all who have seizures have epilepsy. Epilepsy affects about 1% of the population. It is difficult to diagnose due to the diversity and complexity of epileptic seizures. Okay? And if somebody was hooked up to an EEG, you might see some seizure activity in perfectly normal individuals. Just it wouldn't last for very long. Okay, it would just be a small rhythmic rhythmic display of the EEG. Okay, seizures are often preceded by an aura, such as a smell, maybe hallucination, or maybe a feeling. The aura's nature suggests the epileptic focus. Okay, so if it is a smell, then the focal point or foci might be in the olfactory lobe. Okay? If it's something that's visual, then the focal point might be in the occipital lobe. The aura warns the epileptic of an impending seizure. Causes can be brain damage, can be genetic, and they've also looked at faults at inhibitory synapses. Diagnosis. EEGs are definitely going to be used, like the figure that you see on the right-hand side there. Okay, and seizures are associated with high amplitude spikes. So here in the middle, you're looking at an EEG at the onset of a grand mal convulsion. So you see how that very low frequency turns into a higher frequency, higher amplitude wave. Okay. Okay, some more specifics here, because epilepsy is studied quite a bit, but it's also very complex. Okay, so there are focal or partial seizures that do not involve the entire brain, okay? And they are further categorized by simple and complex. For simple, we're looking at symptoms that are primarily sensory or motor or both, and symptoms spread as epileptic discharge spreads. Okay, but again, does not involve the entire brain. Complex partial seizures, often restricted to the temporal lobes, and the patient engages in compulsive and repetitive simple behaviors or automatisms, right? The doing and undoing of a button, for example. And then we have generalized seizures. Now, these are seizures that involve the entire brain. We have tonic-clonic, which is loss of consciousness and equilibrium. We see rigidity here and tremors. So the tonus is the rigidity, the tremors are the clonus. That's why the name tonic-clonic. The resulting hypoxia, which is the lack of oxygen to the brain, can cause brain damage. So these can be quite severe seizures. And then absence is another type of generalized seizure, okay? Another type of seizure that involves the entire brain, but it's not associated with convulsions. Here we see a disruption of consciousness associated with a cessation of ongoing behavior. Okay? So it could be just a vacant look. Okay. What about Parkinson's disease? Okay, so Parkinson's is a movement disorder of middle and old age, affecting about 0.5% of the population. The symptoms are these tremors at rest. Okay. The etiology, Parkinson's is associated with degeneration of the substantia nigra. These neurons release dopamine to the striatum of the basal ganglia. There's almost no dopamine in the substantia nigra of Parkinson's patients. So unfortunately, by the time we see Parkinsonian type symptoms, almost all of the dopamine is gone from the substantia nigra. Okay. Autopsies often also reveal Lewy bodies in the substantia nigra, which are these protein clumps that are prohibiting the neurons from communicating effectively. Treatment: Parkinson's disease can be treated temporarily with L-DOPA. What are these individuals lacking? It's that dopamine in the substantia nigra. So let's see if we can put more dopamine, which is the L-DOPA. Let's put more dopamine into the substantia nigra. And it does have a tendency to be somewhat effective. However, remember what we just mentioned. There's almost no dopamine in the substantia nigra by the time we see these effects. Okay. And then deep brain stimulation of the subthalamic nucleus reduces some of the symptoms, but its effectiveness slowly declines over months or years. Okay. So Parkinson's disease is progressive. There is no cure at this time. We can only hope to extend the life of these individuals through decreasing those tremors with the addition of dopamine in one way or the other, whether through deep brain stimulation or L-DOPA. Okay, there's also Huntington's disease. So Huntington's disease is a rare progressive motor disorder of middle and old age with a strong genetic base. Okay, we have identified the Huntington gene. Huntington's disease begins with fidgetiness, and progresses to jerky movements of entire limbs and severe dementia. Death usually occurs within 15 years, with the first symptoms usually seen around age 40. Okay. Multiple sclerosis. So we'll just list it as MS here, okay? So MS is a progressive disease that attacks CNS myelin, leaving areas of hard scar tissue. That hard scar tissue is what we refer to as sclerosis. The nature and severity of deficits vary with the nature, size, and position of the sclerotic lesions, where those might be. In the figure on the left-hand side, you see areas of sclerosis in the white matter. Okay, so basically here you're seeing gray areas. The tip of those arrows are showing you gray areas where they should be very, very much white. Okay, so they're gray because of the lack of the myelin, which is being deteriorated away by this disease. Periods of remission are common, but again, it is a progressive disease and there is no cure at this time. Symptoms include visual disturbances, muscle weakness, numbness, tremor, and loss of motor coordination. Recent focus has been on epigenetics, which is the combination of or interaction of the genes and one's environment. We do know that MS is an autoimmune disorder. The immune system is actually attacking itself and attacks that myelin. And drugs may retard progression or block some symptoms, but the disease is progressive without a cure. Okay. And then we move on to Alzheimer's disease. So Alzheimer's is the most common cause of dementia. One's likelihood of developing it increases with age. Alzheimer's disease is progressive. Early stages are characterized by confusion and a selective decline in memory. Definitive diagnosis is only possible at autopsy. One must observe neurofibrillary tangles and amyloid plaques, okay, in order for them to actually diagnose the Alzheimer's. Low acetylcholine levels is one of the earliest signs of AD, and they're doing a lot of studies with that right now, and effective treatments are not yet available. So in the figure on the left, you see an example of amyloid plaques. Okay, you can only imagine that neurofibrillary tangles and amyloid plaques would interfere with the communication of these neurons. Remember, the neurons, for the most part, do not touch. They're separated by a synapse where all the different extracellular chemicals are floating around. We have transmitters and everything else in there. And now that communication is not able to take place because of these tangles and these plaques. The figure on the right-hand side shows you the distribution of neurofibrillary tangles and amyloid plaques. So we see a lot of it in the temporal lobe, specific to amygdala, hippocampus. Remember, hippocampus is a big area for memory. We also see the posterior parietal cortex, which that makes sense for sensation, and prefrontal cortex for higher order thinking, creativity, decision making. And so those are definitely functions that are lost with Alzheimer's as well. Okay. I wanted to bring up the issue here of how we're studying some of these disorders. Okay. And so we're using animal models to better understand some of these diseases. Experiments regarding neuropathology are not usually possible with human subjects, so animal models are often utilized. I'll give you some examples here. So the kindling model of epilepsy, we can provide periodic brain stimulations into an animal, okay, which would then elicit seizure activity and elicit convulsions. And that's what we call the kindling phenomenon. From this, we're able to identify focal points. We're able to identify, what starts the seizure, because that's really what we're looking at here. The etiology of these seizures is not well known. Why does it just start in this rhythmic pattern of neuronal firing? Okay. So we can study epilepsy that way. We can also study Alzheimer's disease by actually placing human amyloid into an animal species. Okay. And so you have those amyloid plaques, and they're distributed throughout the brain, and we can identify, okay, what do those plaques really do? How do they affect neurons? And how can we develop better pharmaceuticals that would maybe break down those plaques? Okay. And then finally, in Parkinson's disease, we are able to inject MPTP, which we know will destroy the dopamine in the substantia nigra. Okay. And that lack of dopamine in the substantia nigra is a model for Parkinson's disease. So in this case, now we can identify, how can we replace this dopamine? How can we come up with better pharmaceuticals than just L-DOPA, or electrically stimulate these areas so that the neurons do produce more dopamine, because that is what is so lacking in this area and the result of the Parkinsonian symptoms. Okay. Now we're going to discuss a little bit here on what actually happens to the neurons, okay, because of damage. Okay. And here we start with degeneration or deterioration. Okay. Look at the figure on the left there. Number one, axotomy. And axotomy just means that the axon has been cut. Okay. So we'll refer to purple neuron and yellow neuron. Okay. So the axon of the purple neuron has been cut. Number two, you see the distal portion of the damaged neuron degenerates. So the axon, the distal part of the axon and the axon bulbs is now a dotted line. So that's starting to die off. And number three, then the proximal portion of the damaged neuron may degenerate. So now the purple neuron itself is completely dying. And then four, what ends up happening is that the neurons that synapse onto that purple neuron both end up dying as well. So when damage like this can happen to one neuron, you see how it has an effect on many, many other neurons as well. And then we see that degeneration. Okay. Now, there is some regeneration. Okay. Regeneration is virtually non-existent in the CNS of adult mammals, but can be possible in the PNS, the peripheral nervous system. If the original Schwann cell myelin sheath is intact, regenerating axons may grow through them to their original targets. And that's what you see at the very top of your figure. Okay? When a nerve is damaged without severing the Schwann cell sheaths, individual axons regenerate to their correct targets. So green to green, yellow to yellow, blue to blue, all is good. Okay. But the figure just below that says when a nerve is damaged and the severed ends of the Schwann cell sheath are slightly separated, individual axons often regenerate up incorrect sheaths and reach incorrect targets. So now you see the green going to yellow, the blue going to green, and then the yellow going to blue. Okay. So in the peripheral nervous system, this could be seen as weird sensations. Okay, so somebody loses their finger, they replace the finger, they do microsurgery on there, they try to put the nerves back together again, but it's never really perfect. There might be areas that have some numbness, no feeling at all. Maybe there's some feeling of burning sensation, you know, that kind of a thing. And that's probably because of these neurons not regenerating to the right place. Okay. And then finally at the bottom, when a nerve is damaged and the severed ends of the Schwann cell sheaths are widely separated, there's typically no functional regeneration. Okay. And so whatever sensations there were, they're lost now. There's no connection there. Okay. So just remember that Schwann cells, remember they are in the peripheral nervous system. They do promote regeneration as long as they're not separated too far away. But oligodendroglia, okay, which are the glial cells in the central nervous system that provide the myelin sheaths for the CNS, actively inhibit regeneration. Okay, and so this is why it is so tough for individuals who sever their spinal cord, because the spinal cord is part of the central nervous system and has this oligodendroglia in there that is actually inhibiting regeneration. Now, neuronal reorganization. So reorganization of primary sensory and motor systems has been observed in laboratory animals. The figure on the left-hand side at the top, okay, motor cortex, normal layout. You have the hind limb, trunk, eye and eyelid, mouth and neck, forelimb. They're all separately colored, right? Now focus the one on in the red, okay, and that's the vibrissae, okay, or vibrissae. The vibrissae is basically the whiskers of a rat. Okay, so it's very sensitive. There's actually quite a bit of motor cortex devoted to it, and it makes sense for them to get around in their environment. Okay, if those have been removed, okay, now you're looking at the figure in the bottom. They've been removed. The red portion of the motor cortex is gone. Okay, but it doesn't mean that the motor cortex is not responding to anything. You know, that area that was responsible for the vibrissae, it's not just not doing anything. What it's doing now is it's helping out with the forelimb movements. It's helping out with mouth and neck. It's helping out with the eyes. Okay, so that is a really good example of reorganization. And brain imaging studies indicate that there is continuous competition for cortical space by functional circuits. And for instance, auditory and somatosensory input may be processed in formerly visual areas of the brains of blinded individuals. So you've probably heard the notion that you lose one sense and your other senses become more keen. Okay, that this is what they're referring to here, is that formerly visual areas of the brain might be used for audition or sensation of these people who are now blind. Okay, then there's neurogenesis. Now, neurogenesis is a very, very new science here. It is difficult to conduct controlled experiments on populations of brain damaged patients. Okay, you can imagine that it's very, very hard for us to study this stuff because it is so invasive, right? Trying to get into somebody's brain just to identify how if neurogenesis is occurring, right? Getting into somebody's brain and identifying if things are being repaired or reorganized, okay? Also, researchers can't distinguish between true recovery and compensatory changes very well. Okay? And that's exactly what we were talking about with the reorganization. Was this a reorganization or was this a recovery? Okay. Was this all due to neurogenesis, new neurons, or due to reorganization? Cognitive reserve, education and intelligence, we know that these play an important role in recovery of function, and this may permit cognitive tasks to be accomplished in new ways. And adult neurogenesis may play a role in recovery as well. And so that's what you see in the figures at the bottom. The left panel shows an electrolytic lesion in the dentate gyrus, okay? And number two, the resulting increase in the formation of new cells stained red, many of which develop into mature neurons, which are stained dark blue. So the right panel displays the comparable control area in the unlesioned hemisphere, showing the normal number of new cells. Okay, then we're going to finish up with some issues here with neuroplasticity, okay? Reducing brain damage by blocking neurodegeneration, promoting recovery by promoting regeneration, promoting recovery by transplantation, and then finally promoting recovery by rehabilitative training. So let's start off with our neurodegeneration and trying to limit that. Okay? We do have inhibitors which inhibit apoptosis. Remember, that is programmed cell death. Okay? So these proteins can inhibit that. Also, neurotrophic factors are nearly all peptides or small proteins that support growth and survival of developing neurons. So it's just as important to try to nourish and help grow those new neurons as it is to inhibit them from dying. Neuroprotective molecules like corticosteroids are also tend to promote regeneration. Okay. While regeneration does not normally occur in the CNS, it can be induced experimentally by directing the growth of axons by Schwann cells. Okay. And we discussed that in quite detail in an earlier slide. Okay. Neurotransplantation, transplanting fetal tissue. So for instance, fetal substantia nigra cells are used to treat MPTP treated monkeys. Okay. And this again was part of the Parkinson's disease model. Treatment can be successful, but has limited success in humans. Okay. Transplanting stem cells. So example, embryonic stem cells implanted into damaged rat spinal cords has been performed, and these rats did show some improved mobility due to that. So transplantation is an option, but again, even with Parkinson's disease, we see an initial encouragement because of this abundance of dopamine there, and then it seems to decrease fairly quickly. Okay, and what about rehabilitative training? So monkeys recovered hand function from induced strokes following rehab training. How they do that? Well, they work with constraint-induced therapy, okay, which means they tie down the functioning limb while training the impaired one. And what this does is it creates a competition or competitive situation to foster recovery, so that the individual, okay, they have to use the limb that is impaired, okay? And so it really helps strengthen the connection between, you know, the somatosensory cortex, the motor cortex, the muscle units, you know, all that kind of thing. They're not able to, because it's very easy to, if your left arm is impaired in some way, to just use your right, and you get used to that. And so then now you're not using the left at all. Okay, so also walking is an approach to treating spinal surgeries. After spinal surgeries, or spinal injuries, I should say, but post surgery, they have people up and walking very, very quickly now, okay, because they know how important it is for this rehabilitative training. And also benefits of cognitive and physical exercise. Correlations in human studies between physical cognitive activity and resistance or recovery is definitely viewed. Rodents raised in enriched environments are resistant to induced neurological conditions like epilepsy, models of Alzheimer's, Huntington's disease, which is also a fascinating thing, that in enriched environments, is it that they're getting this nourishment from new experiences and all of these kinds of things that is causing this resistance. We don't know entirely yet, but we're doing a lot of research on that. And then physical activity promotes adult neurogenesis in the rodent hippocampus. So staying active, just physical activity, can cause or is related to the increase in new neurons and in the hippocampus. And remember, the hippocampus is that main area for long-term potentiation, but of memory.